And one of the first questions I asked was, could I change my diet and change the trajectory of this disease? Because it was immediately, you're going on these medications that are going to suppress your immune system. Your risk for cancer is going to go up and da, da, da. And he barked this gigantic laugh in my face and said it had nothing to do with what I ate.
Wow.
And I was like,
I know that.
yeah, I had some choice words because I'm an engineer's kid. I'm obviously technical. I was like, okay, that defies logic, right? A 5-year-old can tell you that a digestive autoimmune disorder has something to do with food. May not be the only thing. And so I started back to school, number one, to get my health in order and do my own due diligence to see what I could do. And then I get into like human biochemistry and I'm like, oh my God, this is it. Not something most people would say. And I ended up going back to school, getting a master's, getting certifications, doing a side hustle, and opened my clinic in 2006.
All right. Well, it's a real pleasure to have Dr. Betty Murray on the show today. Welcome.
Oh, thank you for having me, Zora. I'm so excited to be here.
We were just talking off camera and I was like, we could talk about anything. Like I've been listening to your podcasts and I've been listening to you on other people's podcasts and diving deeper into what you do. And I'm just, so many directions we could take this into, but let's start with because you're a functional medicine doctor and you specialize in menopause and hormones. So let's start with when and how you even started treating women through menopause.
Yeah, first, I'm actually a Ph.D. So I don't prescribe nor diagnose, but I have doctors and clinicians and nurse practitioners and physician assistants that work with me. But I've been in this space for a little over 21 years. And most of my background is clinical nutrition work, human biochemistry, and then integrative and functional nutrition is where my Ph.D. But I didn't really start here. I came to this industry having been in a completely separate industry. And it really came out of my own health crisis. I think almost all of us end up here because something happens to us or a family member, and all of a sudden you go looking for the tool chest and you find that's severely lacking. I got swept into the technology boom in the early 90s. So like the dial-up days, for those of you that are well seasoned in your 50s, you remember that. And I was working for a company as the first female hired into the tech firm, answering to the CTO. It was a brutal environment. And while I was working there, working 100 hours a week, what was once an episodic digestive problem became much more frequent. And I was diagnosed with colitis. And I remember going to the doctor and talking to him about it. And one of the first questions I asked was, could I change my diet and change the trajectory of this disease? Because it was immediately, you're going on these medications that are going to suppress your immune system. Your risk for cancer is going to go up and da, da, da. And he barked this gigantic laugh in my face and said it had nothing to do with what I ate.
Wow.
Like, I was like,
I know that.
Yeah, I had some choice words because I'm an engineer's kid. I'm obviously technical. I was like, okay, that defies logic, right? A 5-year-old can tell you that a digestive autoimmune disorder has something to do with food. May not be the only thing. And so I started back to school, number one, to get my health in order and do my own due diligence to see what I could do. And then I get into like human biochemistry and I'm like, oh my God, this is it. Not something most people would say. And I ended up going back to school, getting a master's, getting certifications, doing a side hustle, and opened my clinic in 2006. So Living Well Dallas was started in 2006 as one of the first functional medicine clinics in North Texas that was also integrative. I had no idea there was no tribe yet. It was just a lot of bravado and a whole lot of just make it happen sort of grit. So we started our practice. I worked with a lot of autoimmune, and several things were very obvious. It was predominantly always women, right? Myself and everybody else included. But when I got into about 38, I had my tubes tied. I didn't want to be on the pill anymore and had to fight to get that. And they said nothing would happen. Nothing would happen. You'd just be totally fine. And within about 6 months of that, I gained about 35 pounds. I started losing my hair, started losing the outside of my eyebrow. Periods became closer together, all this stuff. And I had access to like functional medicine luminaries. I was part of I.F.M.C.P when it was very small. And everybody I talked to, it was like, oh, it's your thyroid, it's your adrenals, it's your this, it's your that. But what it really was is some early onset perimenopause, right? And all the things that I was told to do didn't work, despite it being the cutting edge of medicine and everything else. And so my 40s, my late 30s, all the way through my 40s were terrible. And I was like, if I'm dealing with it like this and I have access to everybody, right? All the research, everybody, I can call people on the phone that are New York Times bestsellers. But at the end of the day, I'm not better That's why I went back for a PhD. I ended up getting a second master's because you always do that just in case you don't finish the dissertation. And I studied hormone metabolism. So how our body processes hormones. And I think there's a lot there that is not elucidated yet. And I not only was able to lose that weight, get it off, feel great. I'm now 56 and I feel so much better. But we've been doing hormone replacement for 21 years in my clinic. And now we have a telemedicine company. And the reality is we could line up 100 different women and we all look different, right? And we all have different experiences of our cycles and everything else. And it's because what works for one woman doesn't work for another. And women's health is underfunded and the research is underfunded, but particularly when you get over 40 and you're no longer trying to procreate. Mm-hmm. And so this is the hill I'm dying on. We're not only going to be treating women properly with precision and predictive activity and preventative, but we're actually going to contribute to the research and collapse the research gap that's necessary.
So you've been studying hormones for decades now and hormone metabolism. I'm wondering if what you learned 20 years ago has changed today.
Oh, yeah. We've got so much more data coming out, everything from genetics, right? So our genetics define, it's not 100% of what's going on, but it's a good 20% of how you're wired, right? So even 20 years ago, genetics weren't commonly available. We had started the Human Genome Project, but we weren't able to do that at scale. And there's still a lot of unknown there. So you got, where do your genetics sort of put you in place? Like, are you good at detoxifying or metabolizing hormones or not? Your epigenetics, how'd you grow up? What are you exposed to? Do you live by a golf course? How many personal care products do you have that are xenoestrogens? All of those layer on top of genetically how you're wired. So your epigenetics, there's just so much opportunity and the data is coming fast and furious, but it's also completely underfunded. So particularly when you look at how we metabolize hormones, we have lots of signals in the research that indicate this is areas for concern for hormone sensitive cancers, particularly in postmenopausal women. But is NIH funding that? No. Is pharma funding that? No, because they don't have a drug to do anything about it. And there is so much emerging data. And I think it's very hard for the average clinician to go through it and understand it. And it's impossible almost for the average human.
Mm-hmm. Yeah. When you said you've been treating women with hormone therapy in menopause for 21 years, that's pretty bold because at the time, everybody was anti-hormones and didn't want to give it. What made you say this is not dangerous and this is actually very helpful?
Yeah. And our clinicians, when the Women's Health Initiative came out a few years before we had opened our clinic, but we had sat down as a group and we go through research all the time. We still do. We have grand rounds, just like you would imagine. And we went through the Women's Health Initiative data. And the reality is most people read the abstract and they never read anything past that first paragraph, which is usually heavily biased. And it's also nowhere close to the full picture. You have a limitation of words. And so you have to be very careful about that wording, number one. And number two, the journals and the media and all those things have spin, right? So a lot of times when you get past that first little paragraph that you see online and you start going through the actual paper, the conclusions do not match what was said in the abstract, or if it does, it loosely matches it at best. So when we went through the data, the supplemental data, and really looked at it, we're like, okay, the Women's Health Initiative didn't necessarily go out and try and exclude every healthy woman, but 75% were overweight, obese, smokers, hypertensive. So if you're not one of those women, if you don't have those risk factors, that study doesn't really apply to you. If you're in the menopause transition between your mid 40s through your mid 50s, that made up less than 30% of the women in the study. It also doesn't apply to you. So we looked at it and said, this doesn't apply. And even more so, large studies, epidemiological studies, retrospective causal comparative studies, and all the other observational studies should inform clinical decision-making, but clinical decision-making should be a one-to-one. The person in front of you and the data that you can capture, understand, and extrapolate as a clinician to understand it and apply it to that person. We are not a population, we are individuals. And so that's always been our stance. And our technology platform we're building is to try and allow for that individualization to happen at scale, right? So women can have that available to them without having to fight for it. And I think that's the problem is everybody wants to just say, oh, well, 20 years ago, we had this study and this is how we're going to look at it without looking at the individual in front of them.
Yeah, it seems like a lot of people at the time weren't reading the study. I think they were all reading the abstract.
They still aren't. Yeah, they still aren't.
And then, of course, then the headlines that were made, and then I read them and go, oh, back whatever 20, 30 years ago, it was like, oh, okay, because this definitely won't do hormones when I get there because I heard they were bad. and so time to, or I guess a different person to say, look, I'm just going to go against the grain, what everybody else is doing, because I just don't see any reason why. And I see the women are being helped with this. And I'm wondering, though, sometimes the doctors that are trying to help women in their 60s, let's say, and say, well, no, you're over 60 and 10 years post-menopause. And the research shows, and they're maybe looking at this unhealthy woman, let's say she is unhealthy and she does fit the profile of the WHI, and they are going to give her the synthetic hormones. And then maybe they're right. Yeah, she shouldn't be because whatever. But I just think that sometimes these doctors who are prescribing the synthetic hormones, they don't seem to know that there is something called bioidentical, or they just say it's marketing, or it's unfortunate that they're not up to it. They're trying to help women through menopause. Actually, the last person I just spoke to, and I speak to women every day who want to try hormones or looking if it's a good fit for them or not. And one of them, what did she say? It was something, the doctor said, so she said, oh, I want to explore hormones. Can you tell me more? Mm-hmm. And the doctor said, no, not now. Let's wait until 6 months. Let's wait 6 months. And then if you want them, I'll give them to you. And I said, but did the doctor ask you any questions at all? And he said, nope. I was like, well, then that's even worse. It's nice that they can offer it to you, but I don't want to be taking hormones from a doctor who's not up on it and just throwing anything in the wind at you without asking you the question. So I see all kinds of stuff. It saddens me because I think the women aren't not getting the individual care like you're giving them, and not looked as a human, and either said blanket no's or yes, but without any real guidance.
Yeah, no, I agree. I'm a scientist and also a tech nerd, right? So when we started our clinic, I remember we bring on a doctor. I'm super excited because she does bioidentical hormones. I sit down, I'm like, okay, give me the math. How do you figure out exactly what the dose is? Because you can compound it and all this stuff. And we sit down and she's like, well, kind of to get their symptoms. And then you start at this dose, you have them try it out. And then if that's not okay, you kind of go up or go down. And then eventually you look at labs and you kind of get there. And I was like, so this is a guessing game. Right? And she's like, yeah, there is. And anybody that tells you anything differently is lying. We do not have any credible data to go, this woman, based on all this data and her body's absorption capacity for a topical hormone, whether it's a patch, a cream, an oil, or a pellet, we have no reliable data to direct that in any real way. We know that those topical forms are way more protective and don't carry risks like your conjugated equine estrogen or your synthetics. But we don't have any real credible data because we basically took all research off the table after the Women's Health Initiative. Now, there's smaller studies that are out there, but we haven't done any really large scale studies. And so instead, you have practitioners that are kind of giving these sort of blanket statements, and they don't even check to make sure that the amount they're giving them is going to protect them from osteoporosis. If there's any indication, regardless of age, that hormone replacement therapy should be on the board, is osteoporosis. Even at incredibly low patch doses like 0.014, we can see almost a 27% reduced risk of fracture. As somebody that talks about bone health all the time, like that is substantive, right? Now, is that enough to do anything for the brain and the cardiovascular system? Probably not. But, 50% of women over 65 will fall and break some large bone, and 50% of them won't make it past the first year. Like, seriously.
Yeah. There's a big misunderstanding. Well, bone health, I can just go on and on about the bones. So I interviewed Dr. Doug Lucas and Dr. John Newstead, who are both bone experts. And it was unbelievable what they said in terms of the studies that show how much estradiol needs to be in your bloodstream in order to stop bone from breaking down. And it was 7 picograms per ml, which is like really low. And then they said just have bone start to form is 20 picograms per ml, which is seriously low. Like when you take hormone, you don't need a lot of hormones to protect your bones. That being said, as doctors who are helping women through menopause for many of the things other than bone, they're like, no, we like it to be, I think it was between 60 and 100 or something like that. They said it's got to be much higher. So it was surprisingly low how much needs to be in the blood for that, just for the bone. But if we want to protect the heart, the brain, and all that, and everybody has their own number. Like some women need to be at 500 picograms, some need at 100. Like we all are different. And this is why I love to test, measure, and assess. So is it true for you? I don't know. Like just because the study says doesn't mean it's going to be the case for you.
Yeah. Yeah. We definitely are the test, don't guess kind of candidacy. We always, and it's funny because blood's not the best way to check for hormones because hormones have drivers, taxi cabs called sex hormone binding globulins. And when you're looking in blood, you can't tell which hormones are in the cab and which have gotten out, which are free. You have to, they do a calculated assessment, but they don't have an exact assessment of how many are free. So if your hormone is bound, it's not there to work. It can't work. But you do want to use blood levels to assess, are we in the ballpark range where the research shows we're going to see improvement? It's the ideal improvement can be in those lower ranges, but are somewhere between 50 and 80, especially for women who might be starting much later in life. But for a woman who's 45, 50, 55, we might see estradiol levels in the 100 to 120, 150-ish range to support all the vasomotor, hot flashes, night sweats, cognitive issues, and all these other things. And so that individualization and the testing must be there. Mm-hmm. And then we always look at the hormone metabolism because we're like, are you packaging this to get rid of it? Especially if you might be on polypharmacy, because a lot of those other meds go through those same pathways.
So I want to give you a little scenario. You get a woman who's in early perimenopause and she's walking into your office and she doesn't have hot flashes, but she says she's unusually tired all the time and she hasn't slept well in months. Some people say years, but let's say she says months. So she knows that there's something off and she suspects that it may be her hormones, but isn't really sure. So where do you start in helping her?
Yeah. So our team obviously assesses all those symptoms. And I think the important thing is we all think that the early symptoms of menopause is hot night sweats and hot flashes. I have had neither one. I've never had those as a symptom. I had a lot of others in insomnia, brain fog, and fatigue, and moodiness, rage, and just not feeling myself, this kind of amorphous, I just don't feel like myself, weight gain. Those were all my biggies. If that's the kind of stuff she's worrying about and experiencing, just the symptoms alone are enough to warrant treatment. Like you don't have to qualify for your hormones. We don't have to wait for vasomotor symptoms. And that's the standard of care, even in conventional medicine. Symptoms alone are enough. Where I think we miss the mark and catch the mark is a lot of times those early symptoms can be sign of progesterone decline. Testosterone declines too, but we have a steady downhill road from 20 onward. So it doesn't get volatile around menopause and then decline. It just has a steady roll. So by the time we're in our 40s, let's say, or even late 30s, it's often already on a decline. So there could be a testosterone problem too. So a lot of times that early assessment is looking particularly in those arenas to see, because some of the things that even wasn't clear to me, despite being in the functional medicine community, was you could still be having a period and have low estrogen, right? Yeah. Sorry, people. It was like, wait, my period's every 21 days. How could I possibly have low estrogen? And if it's fluctuating wildly, you could be catching it on the days it's fluctuating too. So we always look at it and we assess all those things and often initiate hormone replacement therapy and then test to look at it. And I think that's really, really important. I think the area that I really want to dig into from a research standpoint, because I think this was for sure part of the issue for me in the functional medicine community, was I was estrogen dominant. For the women that might be listening, how do you know? Are you a curvy girl? I went from being like a stick to like a C breasts over one summer as a kid. So if you have a badonkadonk butt and your TNA, right, you had excess estrogen just by default. And so I knew all of that because of the perpetuation of stories and dogma in medicine. And I had periods where my estrogen was very high. I think we as a community often wait to treat with estrogen way too late. Because at some point you were estrogen dominant. And I've even met women, because I speak all over the world, I've met women that are like, I'm 58, I went through menopause at 52 and I'm estrogen dominant. I'm like, impossible. Unless you're chugging xenobiotic pesticides, you cannot be estrogen dominant anymore. And so I think the other part too is we have to assess even these younger women and make the assumption that estrogen may need to be introduced much earlier. So for that woman that's experiences those symptoms enough warrant looking at it and treatment.
So do you test and then prescribe, or you prescribe and then test?
Most of the time we test and then prescribe. There could be times that our practitioners will go ahead. Because again, if you look at standard of care, particularly if you're getting the kind of classic symptoms, starting, or if you're in menopause, right? So if you're in menopause and we do a blood level, your levels are going to be rock bottom in most cases, right? And so it may warrant putting a little bit in to actually see where it moves, right? Because if your estradiol is a 5 and your testosterone is a 12 and your DHEA is a 20 and your progesterone's non-existent, we can pretty much guess our way through it. So sometimes we may start and see where it goes. One of the reasons why I lean in both directions is I'm very curious as a researcher about the fate of estrone, which is one of the other estrogens our body produces. And it's the estrogen made in menopause. And it's made by our fat cells. And estrone can convert in the tissue, like your breast tissue, into estradiol and attach to receptors. And often we may not see a lot of the variation there if we don't have kind of a receptor dominant estradiol in the process. So we check both, but almost all the time I won't say almost all the time we are checking labs. We are looking to see that we have efficacy based on research against symptoms, right? So symptoms resolution is always the most important. And then are we treating the things that we're thinking we're treating? And then also, are we packaging and getting rid of those things and providing the best care that we know how at this point?
When you test, are you testing through blood, urine, saliva?
We do. We test through blood first, because again, we're looking kind of, are those levels in alignment? Because we have to remember most of the research was really done on blood levels. So if we're looking like at osteoporosis research, we're looking at blood levels. But urine is a better test for free levels. So how much is available to go out and do its job. And urine also picks up those metabolism pathways that process through the liver that are genetically variable, that can be impacted by your environment, the foods, the pesticides, the herbicides, phthalates, all of those things. We test that once we have what we think is the level dialed in. Symptoms improve, blood levels look good. We test that to see what's happening, because that is manipulatable with diet and lifestyle. Mm-hmm. And we don't test urine early, because if you're at like a 5 on your estradiol because you went through menopause 10 years ago, there's not enough going through the urine to accurately portray the levels. And a lot of those labs don't tell you that. They just let you drop $500 for a lab that's invalid.
What about the woman who's going through perimenopause? Is there a lot of doctors who would say, no, it's fluctuating. It's just a point in time, because today it can be high, tomorrow it'll be low. How do you, I guess, interpret that?
Yeah, there is some variation. So if you're in this sort of chaos zone where estradiol is all over the place, you may be anovulatory, so you may not be releasing an egg every month. So sometimes you may get progesterone increases and not. Sometimes it is a little bit challenging to test for. We can use ovulation testers. We can use apps. We can use the Miro device if we want to get really precise to figure out what's going on. We have that capacity now to test you over time and see what's happening. The other thing is, we know if you're having a 28-day cycle from the day you start your period to the next time you have your period, we know that we can test around day 19, 20, 21, 22. And what we're looking for there is the disparity between the hormones, right? Because it's not just about it's not just about estrogen. It's the relationship between estrogen, progesterone, it's other metabolites. So we try and get aligned there, and then we look at it. And in some cases, we're starting estrogen earlier than what most people assume, because there's still practitioners out there that are like, you got to wait till you go a whole year. At that point, you've lost a significant amount of bone. We've already seen remodeling in the brain and loss of mitochondrial function in the prefrontal cortex. So your brain's not working as well. Why wait?
Yeah. No, I don't think we need to suffer anymore, honestly.
No. I'm sorry. I'm just going to take a jab because this is who I am. If it was a man, we would be handing this stuff out like a frickin' Pez dispenser in a bathroom in every bar in the city. You know what I mean? No man would be told to go through what women are told to go through, ever.
No, 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 I agree. That's why we're here doing what we're doing is trying to empower women so that they
Yes.
know they don't have to suffer. And unfortunately, we have a very high tolerance for pain, much higher than men in general. So we push it out. We don't really need to push through it. So I'm wondering then, you mentioned estrogen dominance. Let's explain a little bit what that is and how if someone is dominant.
Yep. Yeah. So obviously, hormone variability is what kind of defines some of our body shape, right? So if, like I was joking, if you have a lot of up front and behind you, that's usually a sign of a significant amount of estrogen over your lifetime, right? And then if you're more willowy, like I wanted to be the long legs and narrow hips, never had that, because that generally means that you're slightly more androgen balanced. But there are time periods in our life that we are by definition going to be estrogen dominant to comparatively to where we were. So estrogen dominance is the relative relationship of your estrogen cycle from basically being very low when you start your period to ovulation at its highest. And then the secondary peak, which is that luteal phase, that 10 days or so before your period. That, so if you have a lot of fluctuation and very high elevation of estradiol during that time period, that makes you more estrogen dominant. We're comparing it to progesterone. Progesterone comes out after ovulation, and it's actually the collapse of the little follicle where the egg pops out that causes the creation of progesterone. And progesterone fluctuates significantly in that second half of the cycle, and its job is to prepare the uterine lining for implantation. So depending on how your life is kind of going on, you make more or less progesterone. If you're under significant stress, your body will bypass making progesterone to make more cortisol. They used to call it the progesterone steal, but it's more about your hypothalamus and your pituitary, which are in the brain, deciding we don't need to procreate. We need to answer to stress. So you can have lifestyle situations like a lot of chronic stress that will cause progesterone to be lower. And then you've also got the time period of life, which is closer to, in most cases, like your early 40s, but some women like me went through it early, where your progesterone is declining because you're not ovulating all the time. So if that egg doesn't pop out, you don't get the production of progesterone. And by definition, you will be estrogen dominant at that time because progesterone's low relative to estrogen. Right. And so this is where you get into the chaos zone of like fibroids, heavy periods, clotting periods, painful periods, menstrual migraines. All of those things are often tied to this kind of chaos zone. That's either something you were wired with. So some of us had that our entire life, but others will experience it in their late 30s and 40s because their hormones are displaced to each other. And then eventually your ovaries run out of eggs and the production of estradiol and estriol decline rapidly. And that's where we get sort of the menopause transition. But the chaos zone is where you experience all those symptoms.
So you mentioned progesterone being out of ratio with the estrogen. So this is why it's estrogen dominant. Is there a progesterone dominant phase?
Not generally speaking. There can be situations where women are sensitive to progesterone or sensitive to the fluctuations, particularly in the brain. If we look at like PMDD, premenstrual dysphoric disorder, there's a lot of research looking at the potential sort of reactivity in the brain to those fluctuations of progesterone and severe mood disorder. But generally speaking, you don't see a really high level of progesterone in women. It's not usually there. And there's a lot of metabolic conditions that get overlooked, like polycystic ovarian syndrome, which is being renamed because it's an endocrine disorder in insulin sensitivity and its relationship with estrogen. And by definition, those metabolic situations where we are insulin resistant, we've got excess estrogen and usually androgens, progesterone won't meet its requirements, right? It doesn't get high enough. And so they may not ovulate, they may not have periods, but you can have it and still have periods. But by definition, your progesterone's low pretty much all the time. And I think we lack appropriate definitions medically for these sort of variable hormone scenarios There's doctors out there every day going, well, you don't have polycystic ovarian syndrome because when we look at the sonogram, it doesn't look like popcorn where there's polycystic. Well, that's an old definition. That's about this much of the metabolic derangement that kind of fits that thing. And so there's just a lot. And so women sort of suffer because they don't fit this classic diagnosis, and they shouldn't have to.
Yeah, they're told everything's fine, go home, and they feel like garbage.
Yeah, your labs are normal. Based on what?
Yeah. It's, you mentioned the Miro, and I got one. I never used it because it's evidently more interesting for women in perimenopause, but I still want to try it sitting there. But I love the idea. And I think it just sounds brilliant. So tell us a little bit more how you're using this in your clinic.
Yeah, think of it as almost like a glucose meter. It's about the size of a glucose meter. And basically what you do is every day you pee in a little cup and you have these little strips that you drop into it and then you put it in the device. And what it's picking up is your progesterone, your estrogen levels every day. And so it was originally designed to track and help with fertility, because a lot of infertility is a lack of that progesterone peak, right? And so you could see those throughout time. You'd be able to, it also has FSH and LH, which sort of tells you when you ovulate, which can help predict fertility. We do some fertility, but not really. That's not our focus in our physical clinic. But we started using it in the perimenopausal woman that might be early on this transition and she feels like she's all over the place, right? Because if we're checking it throughout the month, we can see what your true fluctuation is right now and help be more targeted about how we intervene with treatment. Because sometimes you might be putting progesterone in early because that's the one that declines first. This is how you can determine, it's one of the ways you can determine, do I dose cyclically? Like, do I fluctuate it and only do it the second half of the cycle? Or should I do it continuously because sleep is an issue and it's not fluctuating as wildly? So it helps kind of personalize that recommendation.
It's so cool.
Yeah, it's so cool. I'm a gadget girl. I've got gadgets all over me,
It's just like the data, like to see what's inside without being invasive. And this is like one of those cool things. And remind me why it's not working for women on HRT post-menopause.
I mean, you could definitely use it because I would say the vast majority of prescribers will get a woman dialed in that's post-menopausal, right? So your hormones are not fluctuating naturally anymore. And our team looks at, are you at those ranges where we know we're getting the protection to the brain, the heart, the bones, and you feel good, right? Again, because that's different for every woman. And we'll look at blood and then we look at the urine to check the metabolism. Could you use the Miro device? In a lot of cases, they're on a somewhat stable dose. They may not fluctuate dosing at all. In a woman who's perimenopausal, there's a high likelihood we might be rotating progesterone in and out based on the time period of the cycle, which makes it more applicable. There are some practitioners that are very into cyclical dosing in menopausal women, and there are some that even recommend keeping a period. I personally don't think that's necessary, and we don't have data showing that. We don't have research showing that we get advantageous outcomes from making a 65-year-old woman continue to cycle by withdrawing hormones. So I think in those cases, if you were going to cycle hormones, you might use a Miro, but when you're in menopause, if you're on a stable dose, you're not going to see a lot of variety.
Yeah, you would. I think I cycle my progesterone in and out. And so I guess all I would see is it's high and it's gone. It's high and then it's gone. Like it should. But this is why I still want to test just to see. I'm expecting this. So let's see. Now I'm wondering if it would help a woman who is maybe not absorbing the estrogen. So I tried changing to a patch and I was like feeling hot at night. I was like, oh, I don't think this patch is working for me. So then I should have pulled that thing out and said, let's see what it says, because I eventually took a blood test and it was too low. Like I just wasn't absorbing it. So I would wonder if the Miro could help me detect that.
And totally in real time, because here's the other thing we see with the patches. Louise Newsom out of Britain has probably the most research here because she's leading up the menopause kind of movement for the medical system there. And she's done some of her own studies, her own population. So Britain has a sort of recommended dose, right? So instead of they're like, this is it. Everybody gets this because it's magical. And
yeah.
Regardless of their entire experience has been different. We're just going to assume everybody's the same. We're cattle. And what she found in her own population was 50% were underdosed on that kind of high dose for women and 25% were overdosed. Why? We have variability in absorption. We have variability in patch placement, skin thickness, vascular activity at the skin surface, interstitial fluid, hydration. All those things can change how you absorb. And we have differences in manufacturers, right? Because in the patch, the actual estrogen is in the glue itself, also an endocrine disruptor. And a woman may get told, this is how you do it, this is it, and she's not getting any better, or her symptoms are weird. And all of those things could apply to why she may not feel good on what she's doing. And if you have a clinician that doesn't have the skill set and the training around that, they'll just kind of go, oh, that's just you. Maybe you shouldn't do it.
Yeah. It's actually, that coincides a lot with Dr. David Rosensweet's research. Do you know him?
We're actually really, really good friends. We are the provider of their hormone replacement in our telemedicine and our clinic. We've been studying it in our clinic for a couple of years before we launched it for the telemedicine company.
Oh, so, good. Okay.
Yes, we're good friends. We nerd out together all the time.
He's amazing. And he's been treating women through menopause for 4 decades or something now. He
graduated from medical school the year I was born.
Yeah, he's got loads of experience. But when he told me, because I took his menopause method with the Institute of Identical Medicine, and I went through that program, and I thought it was super interesting. And I always remember he said in his practice, because he always tests, and he tests before and after, he's done everything. And he said he's finding that only 25% of the women who he prescribes to gets it spot on from the day one and feels.
I would say it's probably even less than that. It's super rare.
Yeah. So, but more or less. So he was saying this, that means that after he tests, they're in the goalpost of where he likes them to be. Fabulous. But then 75% of them either underdosed or overdosed. And that's just what Louise Newsom is finding as well. So it's just insane. How can you prescribe the same dosage and expect the same outcomes? It's not going to happen.
Yeah. I care about a woman's hot flash and night sweat. And again, like I've never had either one of those. Like I had a lot, but that wasn't it. But what I really care about is, are you protected from dementia? Because the dementia research, particularly Alzheimer's, if we look at Alzheimer's in particular, starting hormone replacement early, getting an appropriate dose in can reduce your risk, if, depending on the study, anywhere from 27% up to well over 50% as a woman. 3 out of 4 Alzheimer's patients are females. Right? Osteoporosis, clear indication across the board, regardless of age. And then cardiovascular disease. It is protected to the heart, the arteries, the veins, the small capillaries in your brain, peripheral vascular disease, all of those things, particularly if it started earlier. That's what drives me. We were talking earlier about my mom's experience and going into an assisted living center every day, and they're freaking filled with women. We get the token guy, but for the most part, it's filled with women. And we live an average of 4.5 years longer than men, but in poorer health for a longer period of time. I don't want that to happen to women anymore. And it's because of the Women's Health Initiative. What we're watching are our parents and grandparents getting the effect of hormone replacement being pulled off the table for women.
Yeah, there's things that we can do. Aging, I would say there's a menu of choice. And we can choose how we want to age. And of course, there exists the stereotypical way where we all fear of aging. It exists, and not always a choice. Sometimes things happen, but knowing that we can do things, at least to stack the cards in our favor, no guarantees. Why wouldn't we do it? And Alzheimer's, osteoporosis, heart disease, they don't start when you're 70. They start decades before. So it's kind of like in midlife right now is the time. I believe it's the wonderful opportunity to transform your health to protect your future self.
And I think it's important because people go, well, you think everybody should be on hormones? I'm like, no, I don't. But I think every woman, I don't care if you're a 90, if you want to explore hormones for you, you deserve to talk to a trained clinician who's going to look at you as a person individually and assess you against everything that we know today and determine that. Because we have women that we put on hormones. Like literally, I have a family that we have worked with for 21 years, and we put her on hormones at 63. She's 83 years old right now. And she's like, please, God, don't take them from us. And I was like, well, why would we take you off hormones? She's like, oh, my friends are dead. I'm still playing tennis. It's great. I'm like, what would possess us to do so? So I think that's the message too. We don't have really reliable data to assess women in later in life and where it goes, except for like your osteoporosis data and other things. But that doesn't mean you can't explore it. Too quickly, we're applying population-based data to an individual and ignoring their needs.
One thing I also learned from Dr. Rosensweet was the questions that a doctor should be asking you about your own personal history and your health before seeing if you're a candidate for hormones. As pro-hormone as he is, he says, well, you got to look at the individual. So I have a whole like PDF on this if anybody wants it, and how to prepare yourself for that first doctor visit. But what would you say are the important questions that a doctor needs to be asking you, and what questions should I be asking the doctor if I'm interested in exploring hormone therapy?
Yeah. If we look at some of the important ones, the first thing I want to say is family history of breast cancer and ovarian cancer is not a contraindication for hormone replacement therapy. Having the gene BRCA is not necessarily, because BRCA is a cleanup gene. It's a gene that edits and repairs broken DNA strands. It has nothing directly to do with estrogen. So I think it's also understanding those things. But if we look at the risk factors that we know, right? So we have the Women's Health Initiative that indicated cardiovascular and stroke risk in the women on conjugated equine estrogen, which is Premarin, and synthetic progestins. Very, very different than bioidentical. They metabolize through the liver and they make a bunch of byproducts that increase clotting risk, because they trigger a bunch of clot mechanisms, and especially in older women, even if you don't carry genetic clotting risk. So I think first and foremost is confirm, if you're the patient, that they're not going to use synthetics, that they're not going to use conjugated equine estrogen. You want bioidentical forms. And we use Dr. Rosensweet's products, the Bright. Yes, you can get these from conventional pharmacies also. And then from a practitioner standpoint, we do know that in a small, very small population of women that have what they call aortic stenosis, so narrowing of the aorta, which is the big kind of artery going into the heart, that in some cases, if they're significantly past menopause, the aging activity and atherosclerosis, which is plaquing and hardening of the arteries, can progress to a degree that introducing estrogen, particularly not in a controlled manner, might allow for arterial remodeling, because that's what estrogen does. It protects your arteries. There's a little hair-like structure called glycocalyx that actually helps rebuild, right? So if I haven't had estrogen forever, my arteries are aging, full stop, right? They're getting crusty and old and dried out pipes. If I introduce a bunch of estrogen and I don't sort of control for that remodeling, could it break loose some pieces from that arterial plaque, cause a little bit of rupture, and potentially have risk? We found that in one or two very relatively small studies, but we've identified that. So in a much older woman, we might look at a CT angiogram with like a clear lead to look at soft plaques, hard plaques, and see what that risk factor is. And especially if they carry like familial cardiovascular disease. And I would say the others are, if you're looking at other things, like did you have menstrual migraines and some of those other concerns, your practitioner needs to know that, because getting your hormones dialed in correctly and balanced to each other's will distinguish whether you experience those symptoms again or not. So I think all of those, and there's probably a couple that I'm forgetting from Dr. Rosensweet, but those are probably the biggies that I think about, and that our practitioners, even more so our practitioners. I'm the nerd behind the practitioners.
So great. So we talk about what kind of hormones you may be taking, not synthetic and bioidentical. If you have aortic stenosis or any kind of heart issue because of the estrogen, perhaps causing a little bit of breakup, and while it's remodeling, it's trying to do a good thing, but
like history of stroke. If you've had a history of stroke, especially the clot-based stroke, those things, they need to be explored and discussed. It doesn't mean you can't possibly do it, but you need a clinician that is well aware of how to deal with that and how to assess it before they just throw something at you.
Yeah, if I remember from Dr. Rosensweet, he was saying that if you have a patient like this and she has cardiovascular issues already, you obviously look at those markers and test them like you would any person. I'm looking at that. So,
I test them all the time. Like it's important to look at those anyway.
Yeah. If you decide to go through and say, okay, we're going to start some hormone therapy, there's a way to do it. And you have to, the way I understood it was more go low and slow and take your time. And there's a method behind all of this, which I don't know because I'm not a practitioner. I'm not prescribing, but he's teaching the doctors how to prescribe. And he said, if after 6 months, there's no change or nothing major going wrong or even minor going wrong, then you can feel pretty safe that this is going to be okay. Because things would, if they happen, it would happen within the first 6 months.
Yes.
Is that right? Sound right?
Yeah. And I will say, generally speaking, particularly in a woman who might be postmenopause, so let's say she went through 3 years ago, we tend to always start low and go relatively slow just because a lot of times you don't even know how you feel because you've gotten used to how you feel. So if you look at like observational studies of women, by the time they get about 10 years out, they quit complaining about a lot of the things they had because it's become their new norm. like you quit thinking about it being different because it is where you are. And so I think it's important to kind of go, it's okay to go low and go slow and titrate, which is the increase or decrease of dose over time, because this is a marathon, not a sprint. A lot of women are like, how do I know I'm getting to the right dose? I'm like, girl, this is decades of work to get here, decades of work beyond here. So it's okay to take 6 months to a year to get to the dose that feels just right and is also right for you.
You mentioned menstrual migraines also should be considered or asked, the patient should be asked this. And I've seen several women in our community who have, every time they take estrogen, they get a migraine. They're like, it's triggering my migraine. What is going on there and how can they get around that?
Yeah. So estrogen has a huge impact on the brain, and so does progesterone, but particularly estrogen does, and the fluctuations and the introduction of it. So some of it is to what degree they can handle estrogen, and it might be very little. The other area that I think is most conventional medicine, and especially the research, has never looked at how it's getting metabolized. Right. So when you introduce that estrogens, what is happening at the liver? What are the levels of the byproducts, the thing that the liver does with them? Because I do think that there's probably stuff there and we aren't looking. And there could be occasion for a woman who may be postmenopausal to never do estrogen replacement at all, but they might do progesterone because it's incredibly helpful for sleep, even if you're significantly past menopause. That we have studies showing dosing it for sleep alone because of how it metabolizes in the brain. And testosterone therapy, because testosterone is what your body makes estrogen out of in your ovaries and your fat cells. And sometimes just doing testosterone therapy and getting it into a therapeutic range will improve all those other symptoms and have a slight improvement in bone. It's not the same as estrogen, but it does stimulate osteoblast activity, helps stimulate muscle mass, helps mood and dopamine and other things in the brain without directly doing estrogen. And you'll see a small increase in tissue levels of estradiol that may be meaningful without driving estradiol up.
Yeah, one thing that's worked with some of them is it's the fluctuation of estrogen that's causing the migraine. So when they do it every other day or every couple of days, then they're perimenopausal. So some days they're making it not. So when they run a more steady dosage, we've said, okay, let's check it every day.
Yes.
They found it doesn't trigger the migraine anymore.
Yeah. And it is, especially in perimenopause. I'm glad you said that because I was kind of putting it in the context of a menopausal woman starting. But in perimenopause, it is the wild up and down. I mean, it could be 350 today. It could be 0 tomorrow, right? This would be a great application of the Miro, right? Because you're trying to stabilize across it and you can start seeing what your trend value is. And these are the cases where I think we absolutely, as a medical community, should be researching and figuring out what are those symptoms and laboratory panels that we can identify to help tell us when to introduce estrogen, because we're introducing it too late.
Yeah, I think
in many cases.
I would think the Miro, I gotta get on this Miro.
I think it's amazing, but I wish I would have had it because I think my 40s would have been a lot better because I had been told by every luminary on the planet that I was estrogen dominant and I was just going to have to ride it out. So I waited until the very end and I felt, man, I was just like, terrible. I wouldn't spend another $250,000 on a Ph.D. just so I could understand it better, so I could help.
Yeah, I would think if you're in a perimenopausal phase and you're starting with estrogen, let's say, well, progesterone as well, if you got a uterus, but let's say you were having these fluctuations, I would use the Miro. I would wake up. And if my estrogen is low, I'd be like, okay, today's the day for estrogen. And if I woke up and it was really high, I would maybe want to skip it that day. Again, there's probably not enough research on doing this.
There isn't.
But we're all, the clinical experiences where it's really valuable here. So I would use it like that and see if it would help to say, because the problem when you're in perimenopause is you're still making your own hormones. So then if you decide to take some hormones or estrogen because you're having hot flashes or whatever. But then the day that you put it on, when you're already making enough, then you're going to have another symptom because you're too much estrogen that day.
Yep. Yeah. I'd like to describe it like a ketchup bottle. So, you have a ketchup bottle, and when it's full, you squeeze it out. It's all organic on your all organic, all beef hot dog or whatever. And it's perfect. That's the way it is in your 20s and your early 30s. But then it starts to run out. So you shake it and it spits and puts like a lot, a little, a lot, a little, and then you shake it and then it splats one day and then you shake it 15 times and nothing comes out. That is your experience in perimenopause. And so what we need is research to figure out how to stabilize across that. And that's where I think devices like Miro and our technology that we're building is to integrate things like Miro and your Aura rings and your Hume and your all of those devices to see, can we pick up signals from other places to be able to define that so we can identify it and individualize it to the woman, because we just don't have that data. Because even today, if you're wearing these, you're going to 5 different apps to figure it out.
Yeah. I can't wait until somebody creates like a blood glucose monitor, like the continuous one, and it just measures all your hormones and your cholesterol level. And you get all the data on a hour by hour, minute by minute basis.
Insulin, even better. I'd rather know what insulin's doing than glucose. Yeah. To be able to get that from interstitial fluid, which is the stuff between the cells that we're picking up in those things and those CGMs would be fabulous. It's coming. We'll eventually get there.
Yeah. We got to wait. I got to let you go. God, where did the time go? Jeez, I've had so many more questions.
That's all right.
There was one thing I want to know, and I don't know if you know, and I should probably just go and do the research. So we talk a lot about estrogen being protective for the bones. And it is, if you have osteoporosis or osteopenia, then it's like everyone agrees, like, all right, give her the estrogen because we know it's going to help her bones. And I always say you can't out hormone a bad diet and lifestyle. So as much as I love the hormones, I would still say you got to do your impact exercises and your strength training, and you got to eat the protein, and you got to get the sleep and the stress, like all this stuff that we need to build healthy bones. But I'm wondering, what is the percentage? How much of an impact does estrogen have versus the exercise and the nutrition and the sleep and the stress? Because I've met people who are nutritionists and they are fitness experts and they haven't been on hormones, and yet they still have osteopenia or osteoporosis, and you're shocked. You're like, how? Yeah. So
I have a personal story about that. Yeah.
Estrogen really that powerful. So I don't know if it's 30, 30, 30, 50, 20.
And I've got a pretty deep bench because we've had DEXA in our office for forever. We've been working on osteoporosis for decades. And I will say from my understanding of the research, and I haven't probably done enough due diligence in the last year, we don't have good data to examine across those different areas. We do have good data that just weight training alone, even in a woman in her mid 70s, can put on muscle and bone. Now, the challenge is how much muscle and how much bone did you put on by about average of 30, because it's declining from that point forward. So many of us dieted and did a lot of stuff where we didn't have good bone density. If you're vertically challenged like me, petite, I'm not even 5'3". I say I'm 5'3", it's a lie. So if you're vertically challenged and petite, you don't fit the diagnostic criteria that we base our DEXAs on. And if you go to different areas of the world, like India, they have different reference ranges because of the structural bone size of the average person there. So some of it depends on how much you built, how much you maintained, were you able to maintain it or not? How much can you digest and absorb all the nutrients that need to go into that? And a lot of your fitness professionals also did competitions, which are brutal on the body, and how much did you potentially lose despite lifting weights? So I was diagnosed with colitis, then celiac. I was a power lifter for a long time, and I'm talking heavy, which is why my lumbar looks the way it does. And I went and got my DEXA at about 35, thinking I was going to get this awesome baseline. And I was osteopenic, surprise, surprise, in my left hip, the one that actually needs the joint replacement, at 35 as a power lifter. And I could out leg press most of the men in the gym all day long, every day.
Wow.
It's not just about the hormones. I was on birth control, which I think probably did a number on it. And we know that from stopping ovulation, but I think there's so many other things in there. So weight training alone may not be enough. Good diet, lifestyle, sleep may not be enough. Estrogen is your foreman. It tells the osteoblasts, which build bone, to come to work, and tells the osteoclasts, which break down bone. Only a few of you come in and just do the maintenance side. So when you lose estrogen, Even in a man, I don't know if you know that. In a man, if you cut off estrogen, if you block aromatase, you will cause loss of bone, right? Estrogen is the major driver. So can you preserve and keep it? Yes. Hormone replacement with estrogen is absolutely going to improve it. And especially if you've lost a lot, you may not be able to do enough with diet and lifestyle and exercise alone to get you out of those risk profiles. At least the data doesn't show that today.
Do you test with the REMS scan, REMS?
We do. We do both. We look at DEXA, we look at REMS. If they can get DEXA with TBS, we do that. Our device doesn't have TBS. I could spend $500,000 and buy a new one. I was like, that's fine. We got REMS.
That's great. So in case people don't know, what is DEXA? What is REMS? What are they talking about?
Yeah. So a DEXA device is basically the very large kind of bed that you've seen. And its primary job is to pick up bone density, looking specifically at corticobone. It's very good at that. It's a low dose X-ray. And they usually do your lumbar and a femur, most of the time the left femur. Sometimes they'll do the radial area, which is the inner wrist. And what it's looking at is the density of that bone. And so it's an okay measure, but it doesn't necessarily tell you all the story. When you look at the REMS, or it's called an echo light, what it's picking up, because it's using sonography technology, which goes all the way through the bone, it picks up trabecular bone, which is the inside. And here's how the visual I like to tell people is, imagine you have a house that's brick and mortar, and the outside of the bone, the corticobone, is the stucco you put on the outside. DEXA is very good at picking that up. REMS is picking up the structural integrity of the inside. What does the bone and the mortar look like? And that can be more indicative of the strength of the bone, particularly tensile strength. A really dense bone that does not have tensile strength, that can't flex a little bit, is a fragile bone, right? And so when you look at REMS, that's telling you more about the internal structure of that bone and its health. And that actually moves faster than corticobone. So we like to look at both because we want to understand it. I'll give my reason why. I've had DEXA. We've had it in the office. So it took me 20 years. I was out of osteopenia zone. Everything was good. I got my REMS for the first time like 2.5 years ago. And I get on there and it tells me my trabecular bone is not great. It's just slightly osteopenic. If I had never seen that, I would have assumed I was out of the gray area because the DEXA said, hey, your exterior bone looks fabulous. Yeah. So they tell you different things, but they're advantageous to understand.
I am so glad you know what the REM scan is, because there are very few people who do. And I'm like, why am I don't know about this? It's brilliant, because I don't care about a number. I want to just know if I'm at a very high risk for fracture or not. Am I going to break a bone? So this is where I think the REMS is outstanding, in that it can tell you the strength and that probability. Now, people still will argue because it's new technology and all that, but I still think it's great, because I don't remember the number, but it was Dr. Doug Lucas who said something like 70% of DEXA scans that are showing you have you don't have osteoporosis, that you're clean, and people will have fractures or something like that.
You can still fracture.
It's just crazy. It's kind of like, what? And you hear so many people whose parents have had a DEXA and they're taking medication and they're in the green and they're not osteoporosis anymore. And then they fall and break a bone. Like, well, what's going on? Whereas this is where, or vice versa, right? Like in your case, it's that everything was fine. And then you look at the strength. And I think it's just one of those things that everyone should be doing at any age, maybe from your 20s, more or less, know where you're at. And you can make some corrections if you need to, and avoid the fall and the fracture and all that. Yeah. I love that. Absolutely. I'm going to have to let you go. We've gone over time, and I could talk to you forever. So I always have questions. As much as I know about hormones, I know like a drop in the bucket compared to people like you. So I love picking your brain and learning more from you. So really appreciate your time. And I'm going to have links to your website and your podcast, which I think is fabulous, in the show notes. And you've got a guide of helping women through menopause. Can you tell us a little bit about that?
Yep. So it's a very easy to read guide that helps you sort of go through the things that we went through today, how to create a kind of question and answer for your clinician, and what things do you need to know about your own health, what things you might need to keep track of and express to your practitioner as they try and help you. And then also diet and lifestyle activities that are great for every woman in perimenopause and menopause. So yeah, it's just a basic.
It's a free guide. I'm going to have that in the show notes. We need more information always. And so thank you so much for your time, Dr. Betty. And I can't wait to talk more with you because I still have plenty of more questions. And I don't want to thank the listener. It's just the three of us here. Appreciate you spending your time with us and learning, and highly value your time. And I hope you've enjoyed something, learned something new. And I will see you again the next time, and have a good day, good night, good morning, wherever you're at. And thank you, Dr. Betty. And I hope to see you again too.